All right, moving on to the next presentation, Dr. Shirling Tsai, who is our vascular surgeon, assistant professor at UT Southwestern. We work with her every day. She's tremendous. And she's going to talk to us about abdominal aortic aneurysms, about endovascular therapy versus surgery.
Thank you. First, I want to thank Drs. Banerjee and Brilakis for inviting me to this great meeting. I'm going to talk a little bit about something different from what we've been discussing this morning, abdominal aortic aneurysms, endovascular therapy versus surgery, and I have no disclosures. So abdominal aortic aneurysms, or AAAs, are defined as a dilatation in the aorta, abdominal aorta, that exceeds the normal aortic diameter by over 50%. So by absolute measurements, an abdominal aorta that measures over 3 centimeters would be considered aneurysmal. Nearly all AAAs involve the infrarenal aorta, and luckily most of them are isolated to the infrarenal aorta. So we know that rupture risk is related to AAA size. As the aneurysm gets bigger, the risk of rupture increases. And ruptured AAA is associated with a pretty significant mortality, up to 50 to 80%, even in the EVAR error. So based on this data and 2 large randomized controlled trials that have shown that there's really no benefit to early repair of AAAs, we generally recommend that AAAs should be repaired electively when they get to be about 5.5 centimeters. So here's a schematic that sort of overviews the differences between open repair versus endovascular repair. So in open repair, it's generally through a midline laparotomy, though it can be through a left flank or retroperitoneal incision. And basically, the aneurysm is resected and replaced with a piece of synthetic, usually Dacron or PTFE. In contrast, endovascular repair, the aneurysm is relined. So the aorta is actually relined with a covered stent, and the aneurysm is excluded from the circulation. So here is an example. This is a 3D reconstruction from a patient with an infrarenal AAA. Here are the renal arteries. This is the infrarenal neck, so this is a pretty healthy aorta here, the aneurysm sac, the iliac arteries. So this aneurysm could be actually repaired either open or endovascular. If it were open, it would be through something like this. The patient's head is up here, the feet are down here. This is the nice big aneurysm. It's not actually the aneurysm in the CAT scan, but this is the picture I had. So here's a proximal clamp just below the renal arteries, the distal clamps on the common iliacs, and this is a great operation. It's actually one of my favorite operations to do. Very durable. It's a good operation, but it is clearly not a walk in the park for any patient. This is a big midline laparotomy, probably extending the entire length of the abdomen. Here's the finished product. So this is not something many of you would see a lot. So here are some orienting landmarks. This is the left renal vein. So it's in its typical anatomic position anterior to the aorta. The head is over on this side. The feet are over here. In this case, the proximal anastomosis was reinforced with pledgets, meaning the aorta did not look perfect right there, so we reinforced the wall with a ring of felt. Here, we're actually looking inside the aneurysm sac. So in order to fix this open, we open up the aneurysm, and we sew the proximal graft to the aorta up here, and the rest of the graft actually lies inside what was the aneurysm sac, and then we sew end to end, in this case, to the common iliac arteries here. Contrast this to what we do endovascular. So this is our typical endovascular stent graft, one of several devices we have available to us. And this here is an aortogram from, I'm not sure why it stopped playing, but aortogram from a recent EVAR that we did. And here are some important landmarks. First, we always identify the renal arteries because we want the stent to sit right below the renal arteries. And in this case, we've already deployed the main body, which you can see the markers of the main body right up here. This is the main body on the graft. The main body comes with this part up here and also one iliac limb that's long. And if this would play, you could see the sheath on the big sheath on the left iliac. So the main body extends into the left side, and we cannulated the contralateral gate on the right side with this omniflesh catheter, and when we put a wire through that, we can extend the right iliac limb and make it a bifurcated device. So on our completion angiogram on the next slide, when it gets there, on our completion angiogram, you will see that you can see bilateral renal arteries that are patent and bilateral hypogastrics that are patent, and also the flow through the endograft, but not into the aneurysm sac. Can you advance to the next slide? Ah, there we go. Okay, so Here, the renal arteries up here flow through the endograft, and really no flow in the sac. So the sac has been excluded as opposed to the previous film where you could see the aneurysm sac. This thing that you see out here is actually small bowel. So enough with the videos. So as if that were not minimally invasive enough, we've actually progressed to, instead of doing 2 little groin cut downs to deliver a device, we can do this totally percutaneously. And so can you make it, put the next picture up? There we go. Okay, so so here's an example here. Most of these devices these days can be delivered through an 18 French sheath or smaller. So here is our 18 French sheath in the groin. Here, these little prolines are the ProGlide devices. We put 2 of them in orthogonally to close this at the end of the case. Here we have our bilateral groin access, the big sheath and the contralateral sheath. We deploy the graft, the ProCloses work, and this is what we have left, 2 little pokes in the groin, and this is what the patient sees at the end. 2 little Band-Aids in the groin, which is actually much different from a nice big laparotomy scar with a lot of staples. But clearly the benefits of EVAR extend beyond just the cosmesis. There's actually been several randomized trials comparing EVAR to open aneurysm repair, and this is just 2 of them, the DREAM trial from the Netherlands and the EVAR-1 trial from the United Kingdom. And both of them showed pretty similar results. And that was the 30-day mortality was largely in favor of EVAR, 4.7% for open aneurysm repair versus 1.7% for EVAR. But by 2 years, the benefits of EVAR had largely gone away. This is the midterm data from the DREAM trial, and you can see here that by 2 years, there was no significant difference in overall survival between the 2 groups. And even at 1 year, there wasn't much of a difference. So really, the benefit of EVAR comes in the reduced 30-day mortality. And what about in the long term? So several years ago, both the DREAM trial and the EVAR-1 trial published their long-term results. This is the Kaplan-Meier curve from the DREAM trial, which shows that out to 7 years, there's no difference in overall survival, though there did appear to be a slight increase in secondary reinterventions. Although this can be disputed because the OVER trial, which was the US-run endovascular versus open aneurysm repair, which was actually done in the VA healthcare system here, showed no difference in the rate of secondary interventions. So really, this data and the improving technology has led to a trend over the last 2 decades that has gone from predominantly open aneurysm repair to predominantly endovascular aneurysm repair, such that today the majority of infrarenal AAAs are repaired endovascular. But there are patients with complex aortic aneurysms that are beyond the limits of standard EVAR. And these patients include those with difficult iliac access and especially those with challenging necks, these proximal necks. So a neck that is too angulated or has too much thrombus, too much calcium, or just too short. So the patient really has a paravisceral or pararenal aneurysm. And in those cases, standard EVAR is not going to work. But if those patients are good operative candidates, open repair is actually a very good option. And this is another nice maximally invasive incision. Oftentimes these are done through either a left flank or a retroperitoneal or thoracoabdominal approach, and the exposure is actually fabulous. The patient is often on the side, right side is down, left side is up, and you would be looking, you stand on the patient's left side or the back, and you're looking into the retroperitoneal space. The head is up here, the feet are down here. Here is an umbilical tape around the supraceliac aorta, the celiac, the SMA. The kidney is up here, rotated over, and here is the left renal artery. The aneurysm is over here. So really, you can put your proximal clamp anywhere in here, fix the aneurysm. It's a great repair. It's very durable, but it's also a huge operation for most patients. Not many people will tolerate this supraceliac clamp, not to mention being up in the chest. So in certain patients with good anatomic criteria, we can consider the Cook-Zenith fenestrated graft, which is actually the only fenestrated graft that's FDA approved and available in the United States right now. So this graft actually allows us to move our proximal seal from the infrarenal aorta up into the visceral segment. It allows for up to 3 custom-made fenestrations that will allow for perfusion to the renals, SMA, and celiac, or some combination of the 3 of them. So it expands the options for where we can get our proximal seal. The initial data from this is good. This is actually a couple years old now, but this is the initial US study. And and mean length of stay was 3 days compared to, 5 days is actually very short for somebody with an open ductal aneurysm repair. Sometimes they can be in the hospital for up to 2 weeks or longer. The interesting thing is this, sorry about that 22% rate of re-interventions, which is actually a bit high, but this actually has been shown in subsequent studies also. So some of these fenestrated grafts do have slightly higher re-intervention rates, but so far the data are actually quite good. So this is actually very promising, and there are new technologies that are in the pipeline coming through FDA approval that will really expand the option to more patients. So that's all I have. Thank you very much.